everyone, and Happy New Year, Happy 2023, and for the next couple of weeks' time, Happy Year of the Rabbit. I hope you've had a great time off, and I see lots of people from China. Hope you guys are doing okay. Very exciting to have with us today Professor Steve Abman, who I'm sure you all know. He was one of the first with John Kinsella to use nitric in babies with pulmonary hypertension. And he's been integral to setting up this amazing, I guess, group, collaboration, think tank, research, whatever, about a problem that just won't go away, BPD. So to entice us to join this group for the good of all mankind, and before he goes off to the Antarctic to get even colder than where he is now in Denver, I shall pass the reins on to Steve. But before I do that, Steve, a bit of housekeeping. We shall record this and make sure that no one's doing anything weird in the background. And if Steve is okay with it, we'll post it onto our Dropbox link. And if you have any questions for Steve, please type them onto the chat pane and he'll endeavor to answer it at the end. So I'll shut up now, Steve, and over to you. Thank you so much.
Great. Listen, thank you so much. And Julie, are you able to see my screen okay, the slides?
Not yet. Restart it again, reshare.
Yeah.
Did you try to share again? You can log in and out and start again.
Yeah, let me try that. Let me see if I could do that.
No worries. Okay. Bear with us, everyone. Goodbye, Steve. We'll see you back in 2 seconds.
Okay, great. Okay. I'm going to go to share screen now. And
beautiful. Got it.
Okay. And how's this? Is that better?
Yeah, brilliant.
Okay, good. Okay, thank you. First of all, thank you so much, Julie, for inviting me. It's truly an honor. And I've participated in some of the other sessions you've had as a wonderful seminar series. And I think it's been just fantastic what you're doing here. And that's great. And what I thought I would do today is talk about the BPD Collaborative. And it's entitled Enhancing Interdisciplinary Care. Because what the major focus will be is that it takes a team, it takes a village to take care of some of these complex babies. Takes multiple specialists, multiple backgrounds and experiences. And I think that's the overall message. But first of all, I really have nothing relevant to disclose that would really be related to this study. But my overall objectives here, just to begin with as a background, is to first review the changing landscape of late respiratory and cardiac outcomes of preterm infants with BPD, but especially the development of severe BPD. And I say this because severe BPD has long been overlooked. We've been focused on preventing BPD, which is the chronic lung disease after premature birth. But there is a subgroup of baby who either remains ventilator dependent later in life, meaning near term corrected age, who requires much support because of associated comorbidities, including pulmonary hypertension and many other neurocognitive issues that are part of it. And so they were long overlooked, which was a big reason why we got interested in developing the BPD Collaborative, which I'll also discuss. I'd like to also include a little bit of physiology, a little bit of clinical respiratory management, because I think, number one, it really helps highlight the unique features of their lung disease, their cardiovascular disease, in terms of why it takes so much to get them better, why it does take a number of different folks with different backgrounds to work together to improve outcomes. And then finally, of course, the development of interdisciplinary teams for enhancing both clinical care and research. And so what I'd like to do is first show you the BPD Collaborative, and this is a group of neonatologists and pulmonologists and some cardiologists and nurse practitioners, advanced nursing, and respiratory therapists, and many, many others. And we really got together over a decade ago, informally, to sort of exchange notes on infants with very severe BPD in terms of how we could best manage and improve their outcomes. Again, a little different from a lot of discussions of what causes it, how to prevent it, many of those very vital issues. But really, what's going on with those kids who begin to fill up our NICUs, have long stays in the hospital, are very tough to ventilate, to manage them. And so that really led to this very cordial group of folks I'm showing here. And I'd especially like to highlight Leif Nellen, who's at Nationwide Children's. And Leif is formerly our president of the BPD Collaborative, and he's done a brilliant job. And so I'd like to sort of talk about the collaborative itself at the end of my talk and some of the aspects of it. But I also say part of the reason why we got together was we don't have a lot of data in terms of how to optimize outcomes of these babies. There hasn't been much research. There have been no multi-center randomized clinical trials. God forbid that we have a Cochrane meta-analysis somewhere in the mix. We don't. And so what we do is really have what's shown here. And this is from a coaster that my wife gave me. And it says, if I agreed with you, we'd both be wrong. In other words, we talk a lot, we'd have consensus, we disagree on things. And that was sort of the flavor of the best information as we began to explore how to best manage our kids with severe BPD. But I'd like to start off with a couple cases, and I love using these cases because they really highlight some of the very essential issues. And the first, this was an extremely preterm infant I'll very briefly discuss here. And this baby was born with profound hydrops, severe heart failure, severe respiratory failure, severe persistent pulmonary hypertension of the newborn, or PPHN. And this baby's on an oscillator, as you could see, is markedly edematous, and from the start had profound hypoxemia related to the pulmonary hypertension. So with oscillation, with nitric oxide, with cardiotonic support, with a number of other things we did, we were able to get this baby to survive. And during the course, though, of the weeks in the NICU, this baby failed to show sufficient progress, in other words, getting off the ventilator, or really having marked improvement in oxygen requirement. We had many discussions with the family, with our own staff, much controversy. Are our efforts futile because of the high level of support this baby needed? A lot of controversy, a lot of ethics committee work, a lot of discussion. We decided to persist. We trached this baby, put on chronic ventilation, managed this baby. And then this child, months later, here's the kiddo before she was heading home. She has a tracheostomy in place. She was going home on mechanical ventilation to a ranch in Nebraska. She's a little bit of a cowgirl. And here she is a few years later when she came to have the tracheostomy taken out. And what's really remarkable, and this is what I love, and this is why we do our work, right? She's a ballerina, a cowgirl, a baseball player. And this was early on. She's now finishing up high school. And she's been an all-star academician in high school in her class, going to college. And yet from her rough start, she had all the harbingers of terrible outcomes. We almost didn't support her through her acute course. It's another case I want to use to offset this a little bit, to really show how little we understand about BPD and its late outcomes. This is a 20-year-old college student who was born prematurely, but was barely on the ventilator. There was a history of prolonged oligohydramnios from early rupture of membranes, and this is a child who then needed some oxygen, but was really under the radar until he entered college. And this is where he became more symptomatic, exercise intolerance. And his x-ray shows some hyperinflation and chronic lung disease. The CT shows a mosaic perfusion pattern and patchy areas of overdistension and other lesions. But the worst part of it is this, is lung function testing. And what's shown here, if you look at the loops on the curve on the bottom, this marked concavity shows profound airways obstruction. And if you look at his numbers in terms of percent predicted for the different flows that we measure during standard pulmonary function testing, 60, 35% predicted, 14% predicted in his small airway flow. And yet this was not the child we expected such bad outcomes from, right? He had such a relatively mild NICU course. And yet here he is. I worry far more about him than the profoundly ill, more extreme preterm baby who went through all the critical care problems that a preemie could see during her stay in the NICU. And so what this taught me basically was surprising, first of all, resilience of the developing lung. That if we took some of these severe BPDers who in the past, maybe we would have shut them off. We would have redirected care, we call it, because of futility. And yet here we are with someone with such a great outcome that exemplifies how little we really understand what recovery is all about. Variability of these outcomes beyond the degree of prematurity alone, as highlighted by the second case. And our need for better insights of the lifespan issues, more relevant clinical endpoints beyond what we usually use to give the person a binary diagnosis of BPD or not, and that is having 36 weeks corrected age still requiring oxygen therapy. Then finally, what I really want to emphasize through this is the need for interdisciplinary collaborations. Neonatologists and pulmonologists who have perhaps greater experience in terms of transitioning babies to chronic ventilation with mixed airways and lung disease, who then can follow them as outpatients. The important role of cardiologists in the excitement of using targeted neonatal echocardiography at the bedside that many neonatal services are now providing, I think is really a breakthrough in terms of being more precise with their physiology. Adult pulmonary itself now, as we're seeing some of these adult-aged college kids become adults, and we worry about chronic lung disease, late congestive heart failure, and even late pulmonary hypertension in some of them. And so there's a need for these collaborations, which will be a fundamental part of what I'll be talking about. But first, to take a step back and talk a little bit about the history and BPD and what's severe BPD. Why is it so prominent now? And really begins with Bill Northway, this radiologist who characterized the clinical, pathologic, and radiologic features of BPD. And it's shown here radiologically in 1967, just a minute ago. You see marked hyperinflation with extensive parenchymal lung disease. You see gross anatomy of the heart and the lung prep. Shows marked bubbling, abnormal overdistension of lung regions, suggestive of emphysema, along with the alveolar simplification seen here in the histopathology in the lower panel. And then finally, the vasculature, in terms of the vessels themselves, little brown spots, are very undeveloped, very dysmorphic. So it's this mixture of alveolar and vascular impairment of growth. But it's in this overall picture of striking regional variability in lung disease, profound airways and lung tissue abnormalities that led to such huge mortality in that past era that we thought we were doing better and better, and we are. I think the outcomes have changed dramatically. And a lot of that's highlighted here. This is when we celebrated Bill Northway's 50th anniversary from his seminal observation. Right behind him is another one of our heroes, Alan Jobe. And it was Alan's work that we think of BPD as the then and the next, but Alan is the one who highlighted how we now have this new BPD. That as we've gotten better with surfactant, antenatal steroids, respiratory management early, we still have babies who have lung developmental abnormalities. Not so much the lung injury of the BPD era from Bill Northway's times in the late 60s, still an element of that though. But with Alan, it was more of an arrest of critical signaling pathways that allow alveoli and vessels and airways to all grow together in a way to prevent chronic lung disease. And that really begins in utero, and Alan taught us so much about the antenatal precedents. And so we have to learn more about how to think about this old and new BPD. And again, it's this part of the antenatal stress superimposed with extreme prematurity, which really, and how much better we are with understanding postnatal factors, that leads to the better survival of kids who are born prematurely, and yet they're at risk for late persistent respiratory disease. First of all, prolonged stays in the NICU, and with severe BPD, long stays requiring invasive ventilation in many cases, chronic respiratory problems, readmissions to the hospital, recurrent wheezing, and finally increased susceptibility for chronic lung disease that is very much COPD-like in adulthood. And so those are important things to consider as things have changed over time. That is, the incidence of BPD has not changed over the decades, but as we have more 22, 23, 24 weekers surviving, I think that's what's contributing not only to this persistent risk for BPD, the high incidence, but even the risk for severe BPD. And that is this really immature baby with an antenatal stress who we think really populates most of this group that we'll be talking about. So as you think about evolution from the old BPD of severe lung injury, here's a lung where you see the hyperinflation, you see the flattening of the diaphragms, you see a tube still in place, atelectasis, parenchymal infiltrate. And now over time, the new BPD, where it's far milder. And this is a baby who does not show striking hyperinflation. The infiltrate's more subtle. And so more of an arrest of distal lung development. The baby still needs some oxygen. And histologically, of course, we think there's striking fibrosis in the old, less so in the new. Both of them, though, still have impaired alveolar growth and had vascular remodeling, meaning hypertensive vascular remodeling is shown by the arrow here. But this is sort of interesting. This is the paradigm of the new BPD evolving from the old. And yet what I didn't tell you is that the so-called old from the past is actually a very recent case. In other words, we're still seeing this type of BPD in our units. And perhaps not in the numbers that we used to, but it's coming back. We think a lot of it's because we have such extreme premature babies who are still very fragile in that early period, and we're still at risk of seeing this kind of a child with that kind of severe change in his X-ray that we have to manage in our NICUs. So we think about BPD severity according to the NIH workshop definitions. It was really based on the amount of oxygen and the kind of respiratory support that was assessed at 36 weeks corrected age. None, mild, moderate, and severe. But when we first started thinking about our BPD Collaborative, which I'll get back to in a minute too, we thought, you know what, here's the problem. This is what our discussions were before we formulated this group. What we call severe BPD, and that is having a high FiO2, maybe on nasal CPAP or high flow nasal cannula. We also had these kiddos who are still on invasive ventilation. And we thought, you know, actually within severe BPD, it's too large a catchment. That it's that severe BPD we decided to label as type 1 and type 2, focusing on the fact that the so-called type 2 BPD is really the group that we were really, really concerned about in terms of survival, comorbidities, and difficulty in managing them from a cardiorespiratory and nutritional and developmental status. And so from that idea then as being on a ventilator at 36 weeks corrected, that folks such as Eric Jensen, who's done a beautiful job working at University of Pennsylvania at Children's Hospital Philadelphia, Eric really studied this with data set from the Neonatal Research Network and showed that, look, let's simplify this. Let's forget about the need for oxygen supplementation per se. And if one analyzes the outcomes of our patients, we could actually base it purely on the level of respiratory support at 36 weeks. And he called them no BPD, grades 1, 2, and 3. And so this grade 3 BPD, this invasive mechanical ventilation, is very much that same type 2 severe from the old labels that we gave it. And so Eric did a beautiful job on simplifying this, maybe standardizing our approach and how we could think about at least labeling these kids along these lines from his work. And what Eric further did using the Neonatal Research Network Registry was showed that about 9% of these babies who enrolled from across North America and from an NIH-funded program had the so-called grade 3. So a lower percentage than otherwise, but a very, very important group. And here's why. The outcomes were strikingly related, that is poor outcomes, to having grade 3 disease. Death or serious respiratory morbidities were in grade 3. Neurodevelopmental impairment and death is shown here. But if you look at healthcare utilization, and for those of you involved with healthcare administration and costs and things, This is really a population that we must target, because look who's accounting for most of the cost from these premature follow-up clinics of the survivors who make it. It's the so-called grade 3 or severe BPD. In other words, they most often needed tracheostomy, oxygen therapy, more inhaled medication, feeding tubes, anti-reflux medications. We had to find in-home nursing because of chronic ventilation. And so if you think about it, targeting this severe BPD ends up being a very important issue. Well, what's so hard about it is this, is that the lung pathophysiology is very challenging. And it involves most of the compartments of the lung to variable degrees. So here's a little cartoon picture of what a lung looks like with the central airways and the parenchyma. And each of these compartments has disease. First, the central airways can have tracheomalacia most commonly, which causes airflow limitation, causes respiratory distress, and with any kind of viral infection, really elicits more striking symptoms of disease. Small airways, we always think of them as having asthma-like condition, and they can have responsiveness to bronchodilators, yet it's the mucus gland hyperplasia. It's the structural abnormality of the small airways. It's this impaired developmental dysynapsis of growth between the airways and how they grow and how the rest of the distal lung grows, which is what we refer to as dysynapsis. So it's more than just asthma. And then finally, the distal airspace and vessels. I showed you the histology in the beginning that shows fewer alveoli and vessels, and certainly what's happening distally in these three compartments. We have to target them, individualize care, and get smarter about how to manage them. And so that's illustrated by this CT image, which I found extraordinary, from Rob Castile at Columbus Children's Hospital. And what he did was he looked at the CT in a BPD infant at 6 months of age with severe disease. What he shows by these images is you see these pockmarked areas of overdistension with areas of either fibrosis, edema, or poor recruitment. Very, very different from so many other lung diseases we see, and certainly very much different from acute respiratory problems of premature newborns. So the question is then, how do we put this together with more precision? And again, going back to Eric Jensen's work and his team in Philadelphia, they said, look, let's break it down to the 3 different types of predominant phenotypes. You could have parenchymal lung disease, shown in this circle for the Venn diagram. You could have pulmonary hypertension, as shown here, large airway disease, meaning mostly the tracheomalacia. You find it by bronchoscopy, chest CT, or echoes, but look how many of these merge together, where it's components of each of these that contribute to their disease and severity. So it's not so simple that what we do with pulmonary hypertension is enough. What we do with central airways is enough. How we manage their lungs themselves is enough. It's the interplay of these which makes it so tricky to manage them. And so when we think about how we do manage them from mechanical ventilation, we know their care changes from the time they're born to the time they begin to show signs of established BPD. We could think about it as early, evolving, and established, with the ideas of prevention, modulation, and treatment. And each of these have different strategies, right? Maternal factors, prenatal steroids, delivery room, surfactants, etc. Then with evolving disease, the kids at 1, 2, or 3 weeks of age, who have still persistent needs for oxygen, respiratory support, or ventilation, other medications. And that's really overlaps, but different from established severe BPD in the older population. And so what I'd like to emphasize is how different the modes of ventilation are and how we have to apply it to the underlying physiology to be successful, but they change over time and they change at variable rates with each individual baby. And so that's something I'd like to highlight briefly, which is so unique here. In other words, when we think about a baby early on with RDS, maybe this is the hazy X-ray of pretty profound disease. And you can see the infiltrate itself looks fairly homogeneous. So relatively homogeneous disease. I call it 2-compartment disease. I'll show you why in a minute. But over time, as this baby evolves into severe chronic established disease, you can see the endotracheal tube is here. We see variability. Look how different the x-rays are. So their physiology is different. They have heterogeneous disease. They have one area that's relatively recruited, and yet look at all the infiltrate. We have another region that's completely, the parenchyma is really either edematous or atelectatic or both. And then another region that's just markedly hyperinflated. So the challenges of going from homogeneous disease with what we do with a ventilator to heterogeneous disease can be immense. And approaches that we use to really improve outcomes early are different from late. So to summarize what happens in late severe BPD then, and I'll talk about this a little bit more in a minute, but it's this heterogeneity of lung disease. Variable regions of airways and parenchymal disease, what we refer to as regional time constants. And the time constant is the resistance times compliance, and it changes from region to region. And that's so vital to think about as we manage them at the bedside, and we'll talk more about that. Mixed airways and parenchymal disease, with elements of even some lung hypoplasia, meaning the surface area is decreased on top of the airway and the interstitial stuff that we're talking about, the edema, the atelectasis. Tracheomalacia or diffuse bronchomalacia, the central airways. Airway secretions and manage them far different in the chronic setting than acute. The risk for aspiration, and of course, pulmonary hypertension. So I just want to illustrate one point of why it's so different or how it's so different is when we think about acute lung disease, like acute respiratory distress syndrome, you get an x-ray, maybe this is actually an older child, not a preemie. I just use this to highlight the example. The lungs look a little bit hazy and kind of homogeneous, right? But look what happens on the CT. Two zones. One zone shows the lung here where you see some gas in the lung, the non-dependent regions of the lung. The other zone below it is markedly atelectatic, edematous in the dependent regions. So if you give gas through a ventilator into the lung, where is it going to go? Where it's mostly going to go to these better compliant, more open lung regions. And that's where we worry that if we give too much lung volume or pressure as an equivalent of that, that's where lung injury gets accelerated. So that's where the idea of using small tidal volumes with relatively rapid rates is to protect that part of the lung that's functional and to progressively use PEEP on the ventilator, prone positioning, at least in ARDS, and I think the newborns also benefit from that. We could talk more, to open up or recruit this part of the lung so this can grow as a larger region. But this is part of the basis visually that I like to think about when I think about what happens in lung protective strategies, where we try to keep small volumes, rapid rate, perhaps low PEEPs, and just try to protect the lung while we sustain adequate oxygenation until we get the tube out. But look what happens in preterm infants with ventilator-dependent disease. This X-ray is so different, like we talked about before, with heterogeneity of lung regions. This is the CT scan or another version of it that shows the areas that are over-distended and those that aren't recruited. And so here we have what we call multiple regions of different time constants. And so the challenge then is how to ventilate that lung. So if we use that protective strategy that we really love in that baby after birth, and it's very important to protect the lung, but if we still use it in this older patient, by my cartoon here, you can see that the low tidal volume, the short inspiratory times, and the rapid rate also, gas in this little cartoon here is going into parts of the lung that have the highest compliance and the lowest resistance, and won't really recruit or use the surface area for gas exchange for so much of the lung. So they end up at 100% oxygen. They end up really struggling on the ventilator. But one could imagine if you slow the rate, give larger, slower breaths with longer I times, and allow the gas to fill more sufficiently, all these regions of the lung with different time constants, you could perhaps have better gas exchange, more recruitment, less atelectasis. And so that ends up being part of the overall philosophy from a cartoon basis of how we approach that. Well, does it work? Here's an example of a baby. rapid rate, 36 breaths per minute, 6 mils per kilo tidal volume, so small tidal volumes. PEEP is fairly high at 14, still having regions of atelectasis in the right upper lobe and compensatory or overinflation of the rest of the lung, and is stuck in 100% oxygen for a long time. But simply by slowing the rate to 14, increasing the I time a little bit for better gas distribution, increasing the tidal volume, same PEEP, over just a little bit of time, we open up the lung, have more even distribution of gas, and is rapidly down to 65%. And so that's the kind of change we often see. So in other words, two different strategies. One was very important early, but to persist with these low tidal volumes, rapid rate, et cetera, all these things we do early on, they probably don't work so well in the kind of baby we're talking about with severe BPD. So our overall recommendations then is due to the regional heterogeneity and airways disease, larger tidal volumes in increments, longer inspiratory times, slower rates, because these, with the airways disease and the parenchymal disease, the lungs have got to empty as well. Otherwise they'll get hyperinflated. And that's where the complex role of PEEP. We'll talk about that in a minute. Gas exchange is important, targeting to avoid hypoxemia. We let the CO2 come up. But here's what we really look at with these chronic kids on the ventilator. Our goals is to change the philosophy and care from intubating, ventilating, getting off the ventilator as quickly as possible. We now have a philosophy of chronic supportive care, respiratory support beyond gas exchange itself. So we look less at the PCO2 and a blood gas and more on, is it a comfortable baby? Is the baby having fewer retractions, less apparent dyspnea, synchronizes well with the ventilator? Greater tolerance of cares, can actually undergo the physical therapies, can be held by mom and dad, can be interactive with nursing while on the ventilator. More interactive, engaged, as I mentioned. And so that's the role. And we think of PEEP in a number of ways, and I won't go into this with too much detail, except we use it for small airways. We use it to help open up tracheomalacia, this collapse, this dynamic collapse of the carina that's shown here. So certainly adjusting PEEP to maximize the idea of really opening and sustaining lung volume, having better small airway diameter mechanically, but also to avoid central airways, finding that right balance between the higher PEEP with being able to exhale gas and not have gas trapping from too much PEEP. And this is an example where we haven't done it, right? Dynamic hyperinflation. Look how hyperinflated this kiddo is. Was on rapid rates, along with perhaps too much PEEP. Yet again, simply by dropping the rates, not making other changes, this is in another baby, you can see this dramatic hyperinflation that you see on the left here, going from a rate of 30 to a rate of 14, still on relatively high PEEP, as shown here, 14 in both settings, able to markedly reduce FiO2, have a better looking X-ray that's not so hyperinflated, and frankly, a more comfortable baby. And so we think about that also for how we manage pulmonary hypertension. We know that's vital in kids and contributes to mortality, as shown here, that as kids with more severe PAH have worse survival. We know that a lot of this comes from the severe BPD group. So the challenge then is not only how to manage their pH with vasodilator drugs, but how about ventilation itself and targeting the lung disease along with the vascular disease, the heart disease. These are all things we integrate in the setting of severe BPD that's so vital, and I won't go through this too much more. But those are some of the physiologic and clinical challenges that when we first got together to talk about these babies, we were thinking about. But there are other deeper questions that have to do with their overall care. In other words, there are many problems with caring for these ventilator-dependent BPD infants in many of our NICUs. And if you have chronic disease in an acute care setting, what a challenge that is, right? You've got to take care of the big fires first. The baby who's flown in who needs ECMO immediately. The CDHer who's suddenly crashing with a pH crisis. And so what happens in this setting often is that severe acute illness takes precedent over chronic patients. lost in the shuffle. The other thing we saw very quickly was that there's a feeling that you have to have rapid improvements, and we have to make rapid changes in the ventilator. So there are differences in severe chronic ventilator-dependent BPD with the pace of illness and the pace of responsiveness to therapies, and that has to be part of the assessment. There was especially a lack of continuity of care, especially with such complex children. In other words, every nursery has different schedules, maybe 1 week on service, 2 weeks, maybe a little longer, but then they're done. And so if you have babies who are there for 4 months, 6 months, 8 months, 12 months, how do we maintain that continuity of care and philosophy and experience? And that was a challenge because every new attending has a better idea, right? And there was very little communication because of high staff turnover. We also know this is true at the nursing level and with respiratory therapists as well. Huge issues. We've learned a lot from COVID, for example, about burnout, resilience issues, provider fatigue and stresses. But this has always been a part of managing these kids in the acute care setting. Kids who are spelling, getting dusky. On rounds, there's rarely a clear therapeutic plan articulated and sustained, and very poor communication between attendings and fellows and nurses and therapists and parents. And so those things are all stressors. And here's the communication part of this next line, which is such an essential part of success in their care. And so clearly the need for interdisciplinary approaches, as I've mentioned, and frankly, we really do not have strong evidence for most of our practices, right? Not once when I talk about ventilator changes, which I sound so certain about, right? I shouldn't be, but that's, we don't have MRCT data. We don't have Cochrane meta-analyses. It's based on physiologic assessments and making changes and seeing the response at the bedside, but having consistency in what we're looking for and how we're doing that. And so severe BPD, I say, knows no boundaries. There's need for greater exposure in training within and between specialties, more team rounds. We need to make sure that all the different professions are involved in patient care and have input. Multidisciplinary clinics and case conferences, cross-disciplinary training. Why can't a neonatologist learn bedside echo? Or why can't a cardiologist appreciate the diverse issues, the many issues that complicate what the echo might say about pulmonary vascular disease? Many examples of that. And certainly when it comes to research, we could benefit from it. So it does take a village of specialists, neonatology, cardiology, pulmonary, many different teams and others, developmentalists, case managers, social workers, pharmacists, therapists, occupational speech and physical. So it really takes a programmatic viewpoint to help improve these outcomes of the kids. So locally, this is the kind of schedule we had initially. We had our pulmonary and cardiology consult teams who were actively involved, would be inside the units doing their consult independently, but then come together at least every Tuesday morning for pulmonary hypertension rounds in the NICU, and every Friday morning to go through vent care rounds and look at the whole list of folks who were engaged in the care. And with the NICU care, such issues as how to optimize ventilation, lung disease. What would success look like if we turned the knob on the ventilator one way or another, started steroids or didn't, diuretic, you name it. How about pH management? Is she growing? Is she making developmental progress? Is she having spells? Can we handle her without seeing asynchrony with the ventilator, without having to jack up the FiO2 suddenly because of decompensation? And all of these things are there. And then we talk about planning transition to what we call locally in Colorado, our pediatric respiratory care unit, which frankly, it's just a nice ward area where we have folks who are experienced with the more stable of these babies, that as they leave the NICU before going home, they come up to this ward area where they have continuity of care from the very same providers who are involved in the NICU. Now they're attending pulmonary service who still relates to these different specialties, as I mentioned before. So successful treatment is synonymous with good supportive care. Don't ventilate them to pull the tube, but you want minimal impact respiratory support. Your goal is to support them while preventing infection, right heart failure, optimizing growth and nutrition and development as much as one can. And so when these babies are stable, they end up in our PRCU, they leave the NICU, tolerance of therapies, cares, and handling, less reliance on blood gases, as I mentioned, good growth, We could wean the FI2 early on, but try to keep them on a stable respiratory support when they're comfortable and you hit the sweet spot of the ventilator settings. And so when they're in the PRC, we fine-tune things, get ready for transition to home. And I show this only because I want to show the same teams, the same kind of disciplines that are involved with the NICU. We still need that kind of follow-up. We still have to stay focused on seeing good resolution and transition to home. See that we optimize our approach, not just for cardiorespiratory issues, but development and all the other complications one could see in long-term follow-up. We give the family a clear action plan. And now we have this down to an art where we have, videos, educational videos for families. We are with the families. They have hands-on experience. There's a whole, med sim field now where we apply that with these severely ill babies while in the NICU, who then can the parents can readily transition them to home when the kiddo is ready for that. Does it make a difference? Well, really early on when we started a lot of this, first thing we saw was a remarkable improvement just in survival. And we saw a difference in spirit within the nursery. I'd like to say it's all because of our ventilator strategies and everything, but it's really because the team is talking to each other and the parents are on board and they understand and we're listening to them as well. And then also in terms of costs and things like that, we found that you can get these kids out of the hospital sooner who are trach and chronic ventilator dependent at a lower cost. And we had better survival during the first year of life simply by instituting a team type approach program. And here's the roadmap we designed, starting the NICU. And when you think about a trach and chronic disease, they transition to the respiratory unit before they transition home. And this kind of a little chutes and ladder type of board game. It's helpful for the parents to visualize where they need to go, when their baby's going to be ready, that they get a sense of accomplishment, achievement, the big picture, with all the different frustrations and stresses they have to go through. This gives them something to look at. So we formed the BPD Collaborative. This is our experience I talked about, but it was very much like many other centers. So again, meeting about a dozen years ago or so, we had our own little sessions at the International Pediatric Academic Societies meeting. We talked about the issues we faced, the challenges. We decided to come together and form a collaborative. And the mission was to serve as a catalyst for improving lifelong outcomes of babies with severe BPD, fostering interdisciplinary collaboration and innovation, sharing data, doing a number of quality improvement initiatives, fostering research protocols, and actually enhancing training and development. And so when we started off formally, we initially was an unfunded mandate. There was not a dime in our pocket. Identified needs, clarified goals, developed a registry. We did all these things to get our sites on board. And we talked about clinical medicine and did some early projects together. And then over time, then we've developed more of a rigorous registry. We're working on a biorepository to go with it. We're doing a lot more proactive studies. It's been just an amazing transition. And we've gone from 6 sites to 34 sites. And we have regular case conferences by Zoom meetings that are we just learn so much from each other, from our experience in different ways. And it helps us design better research. We have this organizational chart as highlighted here with many committees that are established, and we're still evolving with those. And we have a number of working groups, and these are open for anybody in the collaborative to be involved with the epidemiology group, the pharmacology group, our pulmonary hypertension group, and certainly the outpatient transition of continuity that way. And so we present to each other from these groups. We promote junior faculty's careers and even senior fellows. It's been wonderful from education and training, as well as being productive for new research. And the old spirit is to create and sustain a culture of collaboration. So with that, it's just been so rewarding taking care of these kids. So thank you. And I'll stop there, and I'm ready for any questions.
Thank you. That's wonderful, Steve. Okay, so you have 3 questions first, but I'll ask you quickly. Do you palliate many of your babies with severe BPD?
I'm sorry, do we do what with the babies?
Do you palliate, stop treatment?
You know, that's such an important question. That's been one of the most dramatic changes. And we certainly still use a palliative care service because of the communication, the quality of communication, and they could identify gaps in how we work with families and address their needs. And the diversity of families, from religious beliefs, fears and anxiety, economic stresses and things that might drive decision making, all of those issues. It takes a whole team, but the palliative care service, actually, even if we're not declaring babies futile very often and redirecting care formally, boy, that service has been a home run, as we say in American baseball. It's been a goal. They're wonderful, and it really opened my eyes to what it takes to really have an effective team, because it can be so hard and disappointing and frustrating, a real roller coaster. But when you communicate, you talk about expectations, there are clear plans, and the parents can see how involved the different disciplines are, the different services. To me, it's really changed the playing field quite a bit. So we don't withdraw support as much as we used to. And we recognize, I go a lot of stories, like that first baby I presented, that's the kind of baby in the past we never would have put the trach in, we never would have sent home to a ranch in Nebraska, and yet that kiddo has been just a superstar.
Amazing.
And so we really changed dramatically. And also the spirit of the nursing staff, to be left in a room alone with a baby who's spelling like crazy, without a plan, without discussion, just frustration. That's really improved dramatically as well, which has been great. And their observations also have helped us with our gaps, not only in care, but also communication and other things too.
Okay, you might be here until your plane leaves from Antarctica. We've got a few questions. All right, the first one is from Phil Henschke in the Mercy. Got it right, Phil? He's asking about high frequency oscillating ventilation in the management of severe BPD. What do you think of that?
I love high frequency oscillators, but not in severe BPD. In other words, when we first started doing nitric oxide, even, I just thought it was such a fantastic way of recruiting lung with more two-zone disease, or what we call diffuse parenchymal disease. And they don't yet have airways obstruction from mucus, from bronchoconstriction, from airways injury. It's rare that we would see tracheomalacia as part of it. But once you start seeing asymmetric lung regions, lung fields, once you start seeing more airways engagement, the idea of needing high mean airway pressure and to safely transmit high mean airway pressure distally, which is what I love about oscillation, is how to do that. It's a different physiology and a different course. And one thing that I love to say here is one of our colleagues, Ed Shepard, who works at Columbus Children's, Ed has this plastic device. He showed me, he used it once at a workshop that we did at the PAS. And the device was a little plastic tube that had all these small little balloons coming off it, like little lung regions. And he could titrate the narrowness of the airways to each of those regions so it's diverse. And he would go ahead and put gas through a ventilator into these. And he could show that if you use standard ventilator techniques, some of these regions would blow up and blow up and blow up, and the others would not open up at all, these balloons. But if you did the kind of strategies we're talking about, larger, slower tidal volumes and things like that, they would more uniformly open up and change with respiratory, mimicking respiratory effort. But what was most striking from this, the reason why I raise it in the context of HFOV, is that this actually was done at a lower mean airway pressure. In other words, even though we talk about the use of PEEP, even though we talk about larger tidal volumes, when you put them in balance, and when you're overcoming airways resistance in the central airways and other kinds of things, you could actually have a more optimized FRC with compliance is enhanced, and you don't need as much mean airway pressure. And it really was stunning to me, because we think that what we talk about is we just dial everything up, right? But we have a slow rate, we have other kinds of things to compensate. And the reality is we're not talking about just distributing higher mean airway pressure. And so when I think about using, oscillators, that's where I think it'd be a little discouraging to apply it with severe BPD. I've seen it done. Our own center has trialed it even in a very severe CDH baby with chronic lung disease. It created pneumothorax. And so I just think it just makes me nervous. And I don't think the physiology we're targeting is something that requires HFOV. But that's, again, more, if you do what I said, we'd both be wrong kind of stuff. I think we need to study these things and see, but that's, as much as we love HFOV for acute disease, not with chronic disease, is my message.
Cool. Okay. 2 questions from our people, Srini and John. We have had a discussion about when to flip over to the BPD ventilation strategy. Srini, you have asked a very long question. Do you want to ask it yourself? Because I can't read so much.
Thanks, Julie. Thanks, Steve. The fantastic talk.
And John, sorry, John, your question is the same thing. So we'll let Srini talk, eh?
I think the question for us is that when do we switch over from acute ventilation strategy to chronic ventilation strategy for established BPD? Like, if the baby is a ventilator dependent, for example, you take a 23-weeker, 500 grammer, maybe it's still ventilator dependent at 3 weeks, 4 weeks from birth. And is that the right age to change over, or we make a staged approach, like those babies based on the chest X-ray? If the lungs look well inflated, maybe we increase the I time first, like slowly, and then like a staged approach, or you go straight to BPD approach with a very long I time, like a low rate, whether that would cause more barotrauma to the baby.
Absolutely right. And thank you for asking the question, number 1. And number 2, you're exactly right that we could cause harm, right? If we did these dramatic changes like a light switch, where one day you're acute, one day you're preventive for lung injury, and then the next day we're on this chronic respiratory support mode. The reality is exactly what you're asking questions about. How can we get smarter about what's in between these 2 extremes? So my feeling is this, that exactly as you said, do it in steps. In other words, use the ventilation strategy to match the changing, evolving physiology. So not going from 5 or 6 mils per kilo, let's say, to suddenly 10 or 12, but maybe little 10%, 20% increments. But if you're increasing tidal volume, what does that mean for gas egress? And so making sure the rate's not too rapid. If you need a little bit more PEEP, do it in small increments. If you want to target oxygenation predominantly in your X-ray, looks a little wetter or more parenchymal involvement. Because during that, we're starting to see the evolution of more respiratory or airway disease on top of the more prominent differential of heterogeneity between lung regions. In other words, very early on, I'm really convinced what happens in the delivery room does make a difference, and good data supports that. I am absolutely convinced that the heterogeneity that we see in severe BPD is set up quite early, where you already have regions that open up a little bit better than others. And we can compound that, especially with too aggressive mechanical ventilation, invasive ventilation. I think it could still happen even with non-invasive support, where these regions will still get a little more prominent. And so how to optimize non-invasive support to perhaps avoid the need for an endotracheal tube. But sometimes if you're on the endotracheal tube and the baby's stable, to make changes that match what you're seeing with the evolution of disease. Like you're saying, if you're starting to see low FRC by X-ray, oxygenation is getting a little worse, lungs look a little wetter, fine-tune those things gradually and target perhaps a little more PEEP and see what happens with oxygenation. You could then think about a bigger tidal volume perhaps, but you cannot tolerate high PEEP tidal volumes without adjusting the rate. Maybe if you're seeing these regions, you have better distribution of gas with a little bit longer I time, but you don't have to go from 0.4 to 0.8 overnight. And those are the kind of transitional things that I think are truly the challenges that we face. Then finally, once you get a baby and there you are, terrible, what we would call cystic looking disease, the terrible X-rays and CTs I showed you, that's when I think, we're a little more aggressive to do what that other type of ventilator strategy is all about. So in other words, it's not just two strategies, but there are two ways. It's a way of teaching about the physiology, but it's really what happens in between the two where all the action is. We've got to get smarter about it. We've got to be creative about it. And I think that's where the evolution, as it's happening, we may actually be able to attenuate severity if we knew what to do in that window of time. So wonderful question. I'm sorry to go on and on about it, but you hit it on the head in terms of what's really important for us to learn more about.
Thank you, Steve.
Yeah, because really, I'm sure you go for it. Yeah.
Just one more follow-up question, if I can. And the other problem that sometimes we see as a neonatologist, when we switch over to chronic ventilation strategy, we have a half-hearted approach in the sense we increase the I time to 0.7, but we rarely drop the rates, and then we end up reversing the ratios sometimes, IE ratios, and then you see very well, like bloated lungs. Is that a right strategy, or we need to be more careful about it?
No, you're also, again, so a couple of the x-rays I showed, sometimes these babies are parked there because, look, I read your article. The baby is now 32 weeks corrected age. Now I'm going to change all my settings. And then, but it's still fine tuning that. And so even though we say chronic respiratory support means you hit the sweet spot for ventilation and leave the baby alone, and when they're ready to wean, they'll wean, the reality is there's still a lot of figuring out to do and adjusting that needs to be done. And so I really get nervous when it's too extreme, either or. And the number one thing, when we have all of our BPD Collaborative case conferences, what I'm really impressed by when we have kids who have hyperinflated lobes and all the right chronic vent strategies are being applied, the rates often still in the 20s or 30s. And you just can't use higher PEEP. You can't use longer I times. You can't use larger tidal volumes, especially with airways disease. And so often just dropping the rate, you could improve exhalation. You could have better distribution of gas, and rate itself. And this is something that George Seinbrunner discovered in the mid-80s. Taking babies with RDS, he showed that rapid rate ventilation, even without severe BPD, can cause inadvertent PEEP. We always think of inadvertent PEEP, we overcome it by more PEEP, but rapid rate itself doesn't allow the lung to empty. And you have this back pressure that's building up and causing more injury. So, so adjusting rate is always something. And it's paradoxical because often the PCO2s are already in the 60s, 70s, or 80s, right? And how can I drop the rate more if their PCO2s are so bad? But you say the reason I can is because I want to reduce dead space ventilation. So by dropping rate with more effective lung distribution of gas, the ventilation is actually enhanced, your CO2 comes down, even though your calculation of ventilation, right, tidal volume times rate, seems lower, but the PCO2 comes down instead of increasing. So anyway, so these are some of the issues, yeah.
Thanks, Steve. So we might take a couple of more questions. We're running out of time, but from your, you know Arvind very well. Hello.
Yes, hi Arvind. Yeah.
Hello. And we've got David Yusuf, who's a new cardiologist who's just joined us. We train in Toronto, and of course they're interested in your bedside echo and what do you give when the baby has pulmonary hypertension, and how long do you keep them on sildenafil for?
Yeah, these are great questions. So something else that we're trying to study as a BPD collaborative too, by the way, Julie. But hey, Arvind, and congratulations to you and your family.
Oh, what happened, Arvind? Tell us all.
My twin boys graduated in December.
Oh my God.
So they were doing medicine. Monesh, thank you.
Fantastic. It's so fantastic. Yeah, so the pulmonary hypertension is so vital, and we really have to figure it out. I just think that the idea of doing serial echocardiograms, and as Arvind has taught us too, making sure we understand the left heart along with the right heart, partly for its contributions to pulmonary hypertension, partly for when our pH targeted therapies don't work or cause more need for diuretics, We have to understand the RV-LV interactions better. We can't simply pull pH drugs off the shelves and be happy that that's the answer. But there's much discussion we could have about how to do that. In terms of selecting agents, for anyone acutely unstable, I still like to go to nitric oxide in terms of really wrap it on and then make adjustments from there. Our second drug of choice would be something like sildenafil, because historically we're comfortable with the NO-cyclic GMP pathway, and that's what sildenafil targets. But there's no evidence that says we shouldn't add something else, like bosentan, an endothelin receptor antagonist. And so I'm really, once I start in the setting of acute PPHN, it's one thing. But when we're talking about moderate or severe pH in the setting of severe lung disease that's more chronic, that's where I sort of slow things down in terms of rapid on, rapid off. In other words, with acute PPHN, often we're trying to target acute cardiovascular stability, improvements in oxygenation from lowering right to left extrapulmonary shunt and that sort of thing. With these chronic kids who don't have recognized extrapulmonary shunt as contributing to hypoxemia, I think it's sort of more of what we call long ball, more of the bigger viewpoint, longer term perspective. And with pH of many different forms outside of premature babies with BPD, we usually start something and give it time to see how things are going in the right direction or not. But when it comes specifically for the question being asked, you have a severe BPDer with pH, what do you do for how long? I start with saying, first, I think about all the respiratory issues that may be complicating life for this kiddo. Hypoxia, lung volume, what can we do with airways management and lung inflammation, et cetera, if they're on the ventilator? Can I decrease the hyperinflation so their pulmonary vascular resistance comes down? Or if they have regions that aren't well recruited, can I increase recruitment to help lower PVR and see what their echo does with time? If they're a little less stable because they're having spells, of course, while I'm doing those things, I feel comfortable starting nitric oxide. And I look for the response. But I use serial echoes. I use serial NT-proBNPs as biomarkers. I don't take these kids to the cardiac cath lab per se, unless there's some puzzling clinical question that we think it will answer. And usually it's something like this, something like the kiddo has a big duct, but I'm not sure if I should close it or does he need more pH meds? And my echoes are not accurate enough. You could have a little more precision, I think, in the cath lab, but echoes are getting better and better. We're learning a lot, and some of it still ends up being empiric. Is there a kiddo who has LV diastolic dysfunction? Sometimes the echo isn't so good at picking that up. And so knowing the wedge pressure in the cath lab helps me. Is there some early sign of pulmonary vein stenosis that I don't want to overlook? And again, with changes in CT monitoring, the imaging is getting better and better. Sometimes we've made diagnoses in the cath lab that we missed by echo. So PVS, shunt evaluation, left heart, those are the major reasons that I would think about, taking a kiddo to the cath lab. And then finally, with real bad pH, and I want to go to a more aggressive systemic prostanoid, I'll often want cardiac cath confirmation of what I'm doing physiologically. And for us, that's a smaller number of babies. And some sites might say, look, I'll start empirically regardless of the cath. But with something so invasive and aggressive, I just want to make sure I'm on the right track, that I'm not missing something structural or these other kinds of things. So those are some general things that I think about with pH and severe BPD, I guess.
Great. Thank you, Steve. And maybe just one last question or comment. Sorry, Prakash, we probably don't have time to go into non-invasive ventilation. We'll get Steve back after his Antarctic holiday. But just a question from Nelly out in Liverpool. How many tracks do you do? Do you have many tracks?
Wow.
I can't find your question.
It's so interesting. It's such a great question because it's starting to grow. It's starting to grow. It used to be very, very rare. And when we first started introducing the idea in given babies, the nursing staff and even the neonatologists sometimes felt uncomfortable because they would say, I've never seen a trach placed in a baby who survived. So it became a marker of futility. And so we would wait and wait and wait, and we just put a trach in because. But over time, we've gotten so comfortable with putting trachs in, and we think a trach is just a trach. It's not a symbol of anything. And it just makes a baby more comfortable when we want to commit to chronic respiratory support physiologically and philosophically. And so the numbers of babies, we have a pretty extensive list in our NICU because we tend to draw from a large region. So, gosh, we did a point prevalence study, and, the numbers were significant in the early centers as part of the collaborative because they seem to stay in the units. They are drawn to these units. So we have extensive experience, and yet I can't give you great numbers of those who got them versus those who didn't, and many comparators like that, because it is a complicated issue in terms of how you decide.
Nila, does that answer your question? Is she still there? She might have left. Yeah, I'll tell her.
Okay.
All right. Okay.
Yeah, tell her to call me.
Now, David, our cardiologist, has asked for your application form. So if anyone wants the application form for the BPD Collaborative, please feel free to email Steve or me. I've got it. There's a price list too. But yeah, certainly it's an amazing achievement, Steve. Well done, and amazing talk. I think it'll be very, very highly downloaded.
Okay. Well, I want to say this though. The BPD Collaborative, I think you would really enjoy engaging with these folks. And we have so many different ideas. We have many commonalities, but we like the creative challenges of when one center does one thing, another does another. How could we explore that? And it's so much fun to have that spirit of collaboration and really exploring questions that come up. And these are real world questions. They're a little different from what one does in other research settings, I think sometimes. Yeah.
Oh, well, there you go. Srini, our director, said we are interested. There you go.
Oh, good. Okay, good.
He's got the purse strings. All good.
Okay. And I don't work on commission, by the way.
Really? Okay.
I don't.
Sure. $5 for you at Pass. I'll buy you a coffee. Oh, you buy me a
coffee. Coffee is different.
You buy me. Okay. All right. Thank you so much, Steve. We won't keep you. It's very late at your place now. Enjoy the Antarctic and have a safe trip. And hopefully we'll catch up again soon.
Great. Listen, it's been an absolute pleasure. I wish we were in person, but I look forward to seeing you folks one of these days soon. But thank you.
We'll work on it. All right.
Great.
Thank you so much, Steve. Good
Okay,
night.
bye-bye.
Bye.